Thank you, and good morning, everyone. Last day of the 37th annual conference. I'm really grateful for the experience. It's been a lot of fun and having all of you here. So thanks for joining us this morning or afternoon if you're on the East Coast. When I started working on Utah's all-payer claims database 10 years ago, our program often felt pitted against the HIE. This last year, while exploring standards for the APCD, CDL, and demographics data, I've come to understand more clearly the different roles the systems and standards play. This health data utility concept that we'll be talking about today is still pretty new to me, but I look forward to learning more from our panelists. So thank you again to all of you for being here. Let me also thank Verado for being this session's sponsor and welcome Sarah Herdman to provide some opening comments. Sarah?
Hello and welcome. On behalf of Verado, I'm excited to introduce our next session, Building an HIE State Health Data Utility. At Verado, we work with HIEs across the US and also state and local government to assemble and share complete and trusted views of patients, including enrichment data like social determinants of health. I hope we'll see you later today in our sponsor booth during the afternoon break. And now, please enjoy the discussion, Building an HIE State Health Data Utility.
Thank you, Sarah. And please welcome this session's moderator, Claudine Williams, to the stage. Claudine is the Deputy Director of the Maryland Health Services Cost Review Commission. So I'm going to bring Claudine on and let Claudine introduce the others. Let me start there. Hi, Claudine.
Good afternoon, everybody. Thank you, Charles. We have a great panel for you here today. My esteemed colleagues from Maryland will be discussing the health data utility, what it is and how it can be a valuable tool to increase access to quality care, identify and address social determinants of health, and reduce healthcare costs. Joining me are my four panelists. First to present is Lisa Bari. She is the founding CEO of Civitas Networks for Health. Next up is David Sharp, the Director of Health Information Technology and Innovative Care Delivery at our sister agency at the Maryland Healthcare Commission. Next is Craig Behm, the newly appointed President and CEO for CRISP and CRISP Shared Services. And finally, we have Ken Yeates-Trotman, the Director of the Center for Analysis and Information Systems at MHCC. So after the panelists briefly introduce themselves, we'll dive into our discussion. All right, Lisa.
Great. Can you hear me okay, Claudine? All right, great. So just briefly again, Lisa Bari, I'm the CEO of Civitas Networks for Health, and we are a national nonprofit organization. We count as members nearly all of the regional and statewide health information exchanges and regional health improvement collaboratives across the country, including the Maryland Healthcare Commission and CRISP and its various affiliates. So we were previously the Strategic Health Information Exchange Collaborative and the Network for Regional Healthcare Improvement, and we started as Civitas last year in October. So as a national organization, we're really working on bringing together this concept of health data utility that's been sort of pioneered by our members, including CRISP and the folks in Maryland. So I've got just a few brief slides. Should I jump into those right now? All right, first slide, please. Thank you. So just really briefly, I'll talk about health data utility. So just kind of do a general introduction before we get into the specifics that are happening in Maryland. So as I said, again, we have members across the country, and they have really been pioneering this model in different contexts, different states, different regions, different settings. And we wanted to, at Civitas, to kind of bring this stuff together and say, okay, what does it look like at the national level? How can we create resources that'll be relevant for folks doing this work nationally in different contexts? So keep in mind, health data utility, in air quotes here, is an emerging concept, an emerging definition. If anyone tells you they are a health data utility, I would say, well, we're not quite there yet. We're still in the process of really fully defining the model. And we're doing that with the support of the Maryland Healthcare Commission, actually. We have a small project we're working on this year that will be delivering sort of some benefit to the entire public very soon. We have a few critical deliverables, including, I think, I would say the most comprehensive set of resources about the work that's been happening on health data utility across the country in the form of an issue brief, kind of like a white paper coming very soon, and also supported by a National Advisory Council of critical leaders in the space, the V1 of a true framework for understanding health data utility. So more to come there soon, and we'll certainly share that through the NATO channels and through our member channels more broadly as well. So when I talk about health data utility, my emerging definition that's really, the benefit of all the people who have been doing work in this space, we say that they are statewide entities or utilities that combine, enhance, and exchange electronic health data across different types of care and services settings, inpatient, outpatient, ambulatory, community, social services, all various different types of settings for different purposes, different use cases, treatment, care coordination, ideally in the future, payment, operations, quality improvement, public health purposes, community health and social services. These are really specific defined use cases. That's how we think about the work that health data utilities do. They have different stakeholders, but overall it is a multi-stakeholder activity governed by a multi-stakeholder group of organizations who really represent the breadth of people who care about how health data is used and collected and in any particular community. And then really important for us is that they go beyond the baseline of HIPAA privacy for health data. They enable greater levels of patient privacy and consent and direction of data. And then this is a really important point for Civitas and its members. We really believe and really orient around the idea that building a health data utility should really build on existing infrastructure in communities, regions, and states. There's so much that's already there, from technical infrastructure to relationship infrastructure. That's really important as well. All right, so brief emerging definition. Next slide, please. So just to put a somewhat finer point on it, we have learned in our work thus far, again, this is a preview of the Health Data Utility Framework project that we're working on with the Maryland Healthcare Commission, so more to come soon. These are necessary conditions for health data utilities to exist. We've got to have state policy levers. They can be various types of policy levers. They can be health data utility defined in legislation or regulation. They can be specific types of incentives. They could even be mandates depending on your state. It's not the same for every state or region. You've got to have broad stakeholder participation. You've got to have provider community, payer community, social services, community-based organizations, public health. You've got to have people deeply involved, patients, patient advocates, consumer advocates. They've got to be engaged in the work at the statewide level. And you've got to have that understanding of the importance of the work. You also, we find, need to have mature use cases in place, working with Medicaid and public health generally. Maryland is a special state for lots of reasons. I live in Maryland, so I can say that. But also because there's just so much engagement and so many years of work around an aligned payment model, the Maryland model, and thinking about ways that these things connect. But this is also present in other states as well. We generally find that you need at least Medicaid and public health use cases to be effective. You also need, as I keep saying, and you'll hear me say again later this afternoon, multi-stakeholder, transparent corporate and data network governance. We really believe firmly that these types of decisions we make about how health data is used must be open, transparent, multi-stakeholder, inclusive. They can't just live with the state government. They can't just live with private firms. They can't live with one party. They've got to be a community-governed activity. And then finally, again, we really need extremely high standards for data privacy and security, going beyond the baseline of at least federal laws, in some cases, state laws that exist today. We're seeing more and more focus around going beyond HIPAA, because as we know, as soon as data is outside of the confines of HIPAA, it can be anywhere and it can be used for various types of purposes. We want to make sure we really have very high standards here. All right, one more slide from me, I believe. Next slide, please. So just again, a little bit more specificity here. There'll be more as you hear from my colleagues here in the panel. What can HDUs do? HDUs can break down the many existing data silos They combine data to enhance data. They also need to be used not just as a repository, but as a living sort of a living repository that moves into actual patient care and into public health activities. They need to deliver data back to clinicians and other providers in the field who are working on these things, on care delivery, care coordination, public health. They need to help us create comprehensive data sets, comprehensive longitudinal medical records, data sets for population health purposes as well, that really help communities prepare, respond, and make these critical improvements in healthcare, public and community health. They've got to help us foster whole person care and reduce provider burden. This is a big one. Many reporting requirements at the federal level, state level, anything in between, and really using the value and the power of a health data utility to help minimize that burden of reporting. That's critical. If you already have a connection, you don't need to build another connection. This was big in the pandemic. You may remember things like requiring hospitals to send bed counts and other things like that directly to the federal government in a spreadsheet. Let's not do that. Let's just do one connection and minimize that burden. And then finally, again, leveraging that existing infrastructure, building on what's already there. Every state in the nation has extensive infrastructure already, and we need to make sure we strengthen that versus build a new silo. So that is, those are my brief intro slides. I'm going to pass it back to my colleagues and happy to talk more about HDU shortly.
Thanks, Lisa. Next up, we have David Sharp, who is going to talk about MHCC and the work that they're doing there and what we're doing in Maryland.
Thank you, Claudine, and hello to everyone. I can't tell you how excited I am, and I think I'm speaking on behalf of my colleagues on the panel. We are to be able to engage you all in a series of questions and answers regarding the whole notion of an HDU in Maryland. So today I have about 4 framing slides to really provide a bit of a backdrop to who we are and what we're doing in this space. It builds nicely on the presentation from Civitas. Lisa mentioned that we are collaborating with Civitas on an initiative to really help develop a framework for what HDUs look like and what they might evolve to over time. We're very pleased to work with Lisa and her colleagues at Civitas on this project. So let me jump right into a little bit about the Maryland Healthcare Commission. We are an independent regulatory agency whose mission is to plan for health system needs, promote informed decision-making, increase accountability, and improve access in a rapidly changing healthcare environment by providing timely and accurate information on availability, cost, and quality of services to policymakers, purchasers, providers, and the public. The MHCC's vision for Maryland is to ensure that informed consumers hold the healthcare system accountable and have access to affordable and appropriate health services through programs that serve as a model for the nation. Our 15 commissioners, appointed by the governor with advice and approval of the Senate, live in communities across Maryland and represent both the state's residents and a broad range of stakeholders. The MHCC is organized around the health systems we seek to evaluate, regulate, or influence, utilizing a wide range of tools in order to improve quality, address costs, or increase access. Next slide, please. Okay. The MHCC is responsible for advancing the adoption and meaningful use of health information technology in the state. Health IT enables treating providers to have more accurate and up-to-date patient information at the point of care delivery and facilitates the collection of information that can improve care management, disease surveillance, and public health data reporting. Broad diffusion of health IT plays a critical role in improving the efficiencies and enabling higher quality of care. Next slide, please. Stakeholders stand to benefit from expanding HIEs to meet data needs beyond traditional use cases. An HDU serves as a critical role as stakeholders work to achieve the promise of digital health. HDUs represent a collaborative data sharing culture, embracing best practices, standardizing processes, and removing inefficiencies to harness the power of data to enable improved services and health outcomes. HDUs are situated to aggregate data to enable innovative use cases that have not previously been possible to address present-day challenges. Next slide. Okay. Generally speaking, the public health response to the COVID-19 pandemic was weakened by chronic underfunding of health systems. Data gathering practices historically have not focused on collecting timely and actionable information to improve access to health services for the most in need. Throughout the COVID-19 experience, CRISP, our state designated HIE, grew to serve as a connector between the healthcare industry and the public. In 2022, the Maryland General Assembly passed legislation that recognized CRISP as the HDU for Maryland. The law requires the HDU to make select information available to providers and health officials. The ability for CRISP to collect, analyze, and synthesize available health and public health data is critical to public health interventions and informed policymaking. I will conclude my remarks by saying that CRISP technical infrastructure and trusted by many stakeholders make it well suited to confront the deficiencies in our health system, information infrastructure, and support a more equitable, integrated, and sustainable system of health to serve Maryland's needs. So with that, I'll turn it back to our moderator. And again, I'm looking forward to having an engaging conversation with my panelists as well as the participants.
Thank you so much, David. And that is a great segue to Craig Behm, who will be talking about the CRISP HIE. Craig?
Yes, thank you. Hey, everybody. I'm thrilled to be here. As you'll hear in this theme, Lisa has the national framework and perspective and has really been leading the way on what this looks like across the country. David and the Maryland Healthcare Commission have been longtime partners within the state to make sure the technology and stakeholders are aligned with that level of cutting edge policy. And now my job is to help implement it. And so I'm going to briefly go through our history implementing it, and then we'll turn it over to Kenneth at the very end. Let's pull up the slides. This very briefly about CRISP. We are the state designated health information exchange, in addition to now being the health data utility. And really that meant that we have a long history of working across the continuum of healthcare to make sure data is interchanged in secure and efficient ways. We spend a lot of time through building cooperation and collaboration. And so we are a natural place to consider adding new use cases, new data feeds, and new considerations in terms of SDOH or public health. Next slide. The next slide, you heard David reference the legislation, thank you, that was just passed. And there's a reference on here if anyone's interested. And really, you'll note that this builds on the mission and vision of the HIE in ways that, as Lisa highlighted, are really supporting the communication between public health officials and healthcare providers, but also supporting interventions so that data can be shared one time and repurposed for all sorts of new and exciting reasons, which I'm sure we'll get into. Next slide, please. And so let's talk a little bit more about what we actually do here. Maybe I'll use immunizations as an example for how we're enriching, distributing, and enabling different things with this data. And so as an HIE, we had been supporting bidirectional immunization data exchange. If you're a provider in Maryland, you can submit immunizations through essentially secure channels hosted and maintained by CRISP. But we pass it directly to the Maryland Department of Health, where they can add it to their Immunet system and the source of truth. During COVID, they started sharing the actual Immunet data with us. So it was not the individual records, but the source of truth database. And we were enabling different use cases, mostly in terms of driving additional uptake of vaccines and making sure there was equitable outreach programs. What we found very quickly, though, was that we could also enrich the data within Immunet, We have a master person index that we've spent many, many years tuning and adding to and generating golden records. And we found that actually we were able to identify potential either bad linkages or duplications within Immunet that we could pass through to their business analysts to potentially address. And so even just by sharing the data with the HIE, or now HDU, we could make sure that data was more effective in its source system. We could also add things like updated phone numbers, demographics, race, ethnicity data that we could source from other places. In terms of distribution, because the data was shared once and we have various methods for sharing the information, we could do things like push analytic files to Maryland's Department of IT so they could post public reports. We could send data to the health systems or local health departments through secure Tableau reports. And we could even give data back to folks like the Secretary of Health so they could have some strategic data-driven insights.
Sorry, finally, I'm seeing some comments in the chat that people can't see the slides. I'm not sure if we need to reload or something, Charles.
Thank you, Lisa. Hopefully that's better for folks. You don't want to miss these slides. They're good. Now I will paint a picture with words also, if that helps. But finally, the thing I'm most excited about is that because the data is at the person level for healthcare purposes and treatment within kind of the HIPAA world of health information exchange, we were also able to enable interventions. And so you could have aggregate data coming from, or aggregate kind of strategies that are data-driven that the Secretary of Health wants to initiate. The data could then flow through a secure platform and the HDU, and then actually go to providers at the point of care at the person level. So you could really tie these high-level state strategies and individual patient interventions. And we're hoping that over time, certainly we saw some short-term outcomes when the public health officials had very deliberate programs. But I also think that over time, we're going to see, the needle move really dramatically more than maybe it has in the past. So let's go to my last slide.
So it appears that our slides are not working consistently. So if we are unable to share them, Craig, I guess you can just kind of talk through the next one. We'll definitely make them available afterwards. Apologies.
Yep, that sounds good. And so the key on this last slide, we're really talking about challenges and opportunities. And I will say very humbly that in the health information exchange world, for the past 10, 15 years, we've been working in a space where there was no data being exchanged. And so if I could exchange a little bit of data, it was better than no data. And in the health data utility world, that's not good enough. We are critical infrastructure and we need to achieve 99.9% uptime. And we need to have higher data quality and standardization. This is not just data to support other clinical records that a clinician might be using. This is data that may only be from this source. And it is essential that it's always flowing consistently and appropriately. That said, we're not policymakers. We are still facilitators with a health IT platform. And so a lot of the collaboration we do has actually been enhanced because now we're collaborating with more individuals, but we do need to take stakeholder involvement, and governance becomes a very serious focus of ours. And then finally, I'm excited, the fact that our Healthcare Commission and that our Civitas kind of network affiliation is creating opportunities to do this work across other places. A Maryland solution might solve a Maryland problem, but we have plenty of scars and lessons learned and are thrilled to share them with other places so that this type of infrastructure can be enhanced and tailored and can fit everyone else's local problems as well. So with that, I will pass it back to Claudine.
Thank you so much, Craig. And finally, we have Ken Yeates-Trotman, and he will talk about the APCD and its role in the health data utility. Ken?
Thank you, Claudine. Again, my name is Kenneth Yeates-Trotman. I'm Director for Analysis and Information System at the Maryland Healthcare Commission. and I'm responsible for the development of the APCD and management of it, of the state APCD. The Maryland Healthcare Commission is an independent regulatory agency whose mission is to plan for healthcare needs, promote informed business decision-making, increase accountability, improve access in a rapid changing healthcare environment by providing timely and accurate information on availability, cost, quality of services to policymakers, purchasers, providers, and the public. Now, I see the APCD as a source to the health data utility, providing the claims administrative data to the health utility. I'm going to go through here just to give a quick background as to what the APCD includes. Just like any other state, in Maryland, the APCD includes data from commercial payers, and these are folks who are enrolled in privately insured plan under a Maryland contract, meaning those contracts that are written in Maryland, and these will be made up of Maryland residents and non-Maryland residents, and the folks who are on a non-Maryland contract, meaning that those contracts are written outside of Maryland, and these will consist of only Maryland residents. We have been collecting data for a long time, beginning in 1996, and currently we have over 12 years of data available from 2010 through year to date 2022. To give a snapshot as to the distribution of covered lives at the end of 2020, we have about 4.6 million members, and it's distributed by about a little bit over 2 million on the commercial side, and about 1.5 million for Medicaid, and about 780,000 for Medicare, which includes the fee-for-service and Medicare Advantage. Next slide, please. Okay, so over the 5 years, starting in 1996 and most recently in 2019, the APCD, just like any other state, have encountered some tremendous headwinds because of policy actions by the federal government. So, for example, on March 1st, 2016, the Gobe versus Liberty Mutual Supreme Court ruling exemplified the self-insured ERISA health plans from reporting data to state APCDs, including Maryland. That has been very devastating to Maryland. The impact is about 1.1 million members, or about 31% of our privately insured population. Then you fast forward to the summer or the spring of 2019, the Office of Personnel Management claimed an ERISA equivalent exemption prohibiting all payers who have contracts with the office from reporting federal health plans data to state APCDs, including Maryland. That decision resulted in about 580,000 members, or about 21% of the remaining privately insured population after the ERISA loss. Now, when you combine these two large populations, it accounts for about 1.68 million, or about 44% of our privately insured population. Now, these are devastating losses for the APCD, and we see the APCD as a source to the health data utility. So it's very, very challenging to overcome these headwinds. Next slide, please. So despite these challenges, the APCD remains our best source of claims data. We strongly believe that we will and we can limit the impact of these data leakages by continuing to engage payers and employers to voluntarily report ERISA data to the APCD, and also to let them know that it is important for the data to be included in our data set. Also, some payers do give employers the option for an opt-in option to include the ERISA data, and we have a handful of payers who are actually doing that. We will continue to collaborate directly with our self-insured ERISA friends and to let them know that their data is very important and could benefit them, which can lead to health benefit designs which focus on high quality and low cost of care for the organizations. So in other words, we need to show these employers what is in it for them, reporting their ERISA data to APCD. Also, we will, in the future, we will like to explore the data in the clearinghouses as a possible source to narrow the gap for data leakages. As you know, these are electronic transactions that goes from a provider to a payer. And within that bay of data, we would like to capture that information to examine it. And we'll start off by examining what we know, starting with the privately insured information. And if we can identify those and match those with what we have, we will find a solution for these data leakages gap. Also, lastly, we will continue to communicate with the Office of Personnel Management regarding getting the federal employee data back in the APCD. But more importantly, the APCD continues to fully capture the insurance markets that are regulated under Maryland law, such as the individual market, small group market, and the regulated large group. And that's conclude my presentation.
Thank you so much, Ken. All right, we're about to get into the discussion part of our presentation. Please put any burning questions that you have for our panel in the chat, and we'll definitely ask your question. So this first question is for all panelists. In your view, what is the most important aspect of a health data utility?
I can jump in if that's okay. From my perspective at the national level, I would say that the most important thing is that you are truly providing value to a disparate group of stakeholders in a specific jurisdictional region. And as I said before, I think some of those have to be Medicaid and public health, but there also have to be other value sets being provided to the private sector in the healthcare community in that region or state. And so we, again, generally find that the emerging successful models across the country are doing both. They have meaningful engagement in providing real value in terms of data, insights, and care delivery support to Medicaid and or public health or some part of the state healthcare apparatus, and then also have deep engagement with the private sector. So it's really that true multi-stakeholder engagement and also delivery of value. If you are thinking, maybe some of you might have experience with HIEs from 10, 15 years ago when you're talking about simply participant user fees, basic clinical data exchange. This is far beyond that in terms of actually delivering real value through the exchange and the enhancement of health information. So that's my take from the national level, and would defer to others on what they would add there.
Yeah, and I might sort of build on that a little bit. I think Lisa did an excellent job sort of describing it, the value of it, and I'm sure my colleagues will continue to note areas of value. I would point out that there's a particular value in when you think of population health and public health data. And I'll use the perfect example I noted in my sort of framework slides, which was the experience we had with COVID-19. During that time, what really highlighted the value of the HIE then was its ability to address public health needs by taking data that would support and address some of the population-based and public health policies around the COVID by being able to report data that historically we wouldn't have had access to. And the work that Chris did was to be able to stand up these data sets, connect to these data sets, and then analyze, interpret, and feed it back to the public health officials in a way that we could provide meaningful decisions and actions to the leaders on point for how this pandemic was handled in Maryland. So that was a real telling experience. And we hope that there's not another public health emergency anytime in at least our lifetime. But the good news here is we think we're ready. And we think if we're not there yet, we're pretty close. So I would say the ability for an HDU to take data that's available and used historically in isolated silos in the public health world and present it back to all of population health for those particular needs was just one of the largest aspects that we took away from this emerging growth towards an HDU.
So I could
Great.
jump in.
Oh, go ahead, Ken. Yep, I was about to point to you. Go ahead.
Okay. Yeah. So thank you for that, Bill, and what David and Lisa had said. So for me, I am so intrigued that the health data utility is the ability to collect a wide range of health data, such as clinical information, public health information, and also claims and administrative data, and then combine or integrate that information through various data analyses, and then use health information technology to disseminate this information to a broader statewide audience, to increase transparency and improve communication between, health plans and providers and healthcare organizations, and in so doing, reducing costs, improving quality, and expanding access, which will hopefully result in better health outcomes for patients.
Thanks, Ken. And lastly, Craig, what do you think?
Yeah, I mean, maybe I will, for the sake of sounding like my organization is less important, I'll say it's the health IT the IT systems and platforms are no longer the barrier or the challenge in setting this stuff up. I mean, certainly having the privacy security frameworks and knowing how to handle the data and ensure data quality and monitoring the feeds is all kind of now table stakes. But to me, the most essential thing is having partners that trust us with the data, that are creative with use cases, and that are willing to understand the value of kind of a single source of data flow, both because it reduces the burden from the data senders, but then also because we can do all the great things, Kenneth and David and Lisa just talked about. And so I would say none of us want data for the sake of data, and the vision of the partners to buy into the utility model is really the most important step.
Yeah, if I can add then to that as well, just to follow up on that, I would say you made a really important point we should probably continue to reiterate here, Craig, which is that, when we talk about a health data utility, we are less talking about a specific technical infrastructure. We are more talking about the unified governance of health data within a particular jurisdiction. And I think on the technical side, it's important to also mention to our colleagues here who work at the national level, in no way, shape, or form should the development of health data utilities impede the national interoperability and health data exchange and use goals. In fact, we believe with this work, we can better coordinate, use standards more consistently, and better adhere to implementation guides for specific, standardized uses of data, from the claims to the clinical side and everything in between. But again, that the health data utility is more about the governance and coordination of the use of health data with an eye to community governance versus a specific individual technical infrastructure. So just to say that as well again, and to reiterate what you were just saying, Craig, it's really less about specifically who is running the technology for that particular aspect of the health data utility. It's more about the coordination. That's also kind of a little bit of a myth buster from people who maybe have experiences with the HIEs from 15 years ago. Today's HIE organizations, today's proto health data utility organizations don't use homegrown technology. In many cases, they use modular, best-in-class technology that adheres to data standards as well.
Yeah, and I would just add to the point that Lisa made one word, and that's interoperability. And when we think of what interoperability means today and what it meant 10 years ago, it means something very different. And because to Craig's point, it's not a technology solution so much as it is imagining the use cases that you can develop when you have widespread interoperability, both within a state and across states, which is a lot of what the national efforts are really going to help advance. So it starts local and then becomes national. And the challenge will be for us to make sure that the policies around its use are interoperable as well, because each state will have some uniquenesses that, for whatever reason, they feel it's important to them. So having the ability for policy to be interoperable so that the wishes, if you will, of the people of a state are respected through the data sharing process. That's something we have to keep in mind as we move forward.
All right, most definitely. And to piggyback on that conversation about policy and data security, and we know that when we're sharing data across different agencies or across different states, we want to make sure that the security and privacy is fundamentally, at the top of our list. So what privacy and security policies that states should consider that are critical for governing the access, use, and disclosure of electronic health information? And this question is for David, Craig, or Lisa. Do one of you want to jump in and answer the question? David, it looks like you're ready to go. Go ahead.
So it's important. Again, I started out by saying each state has uniquenesses around privacy and security policies, and they all build on HIPAA. Few states or few HIEs say, well, we have HIPAA, which was amended by ITEC, so we're good to go. Those days have long come and gone. In Maryland, we worked a lot with stakeholders, the representatives of the HIE. We tried to make sure that we had diverse representation. We convened what we call an HIE policy board. It's been a long-standing work group that goes back probably to 2010. And they've done terrific work in bringing forward the wishes of the consumer population. Key areas of focus that we have in Maryland specifically relate to the rights of a healthcare consumer concerning information access, used, or disclosed. I'll give you a few examples. Access, use, and disclosure of sensitive health information. Particularly, we focus on remedial action to be taken in the event that there's a breach and a breach notification process. HIEs that meet the definition of a health information exchange set forth by the Maryland General Assembly are required to register with the state, with the MHCC, and are obligated to follow the existing privacy and security regulations that are in place. And we also have abilities and regulations to use data in emergency purposes. The regulations are broad and deep, but fundamentally figuring out what the population of a state is comfortable with, the different stakeholders, is extremely critical to being effective. I'll say this, it gets to, I think, in my view, where people don't often remember the 1,000 great things that you do. But if you do one thing wrong, that sticks in people's mind the longest. And as it relates to privacy and security of health information, that is one of the most valuable lessons one can take away. And so it's hard because mistakes happen. But this is an area where we have to do really well to ensure that mistakes don't happen. I mean, I'll give you an example. Would you want a mistake to happen when you were by the pilot who was flying you on your dream vacation? They do this kind of work with perfection, and this is the kind of work we have to do with HIEs and HDUs.
Great. Lisa or Craig, you want to jump in?
I'll maybe just note that as more data is consolidated in a single place, I think these policy and security policies can and should be refined and tightened. David and our colleagues at the Healthcare Commission have been really on the cutting edge of that as they think through what consumer protections are appropriate, what does consent mean, considering various use cases and level of data access. I think we're also finding that patient privacy only matters as much as what level patients understand their data is being used and at across which different domains and for which purposes. Part of the legislation to establish the health data utility in Maryland was to also create a consumer advisory council. It was modeled like a PFAC at a hospital. And while that's certainly going to be more of a challenge for my organization to engage new stakeholders and educate them and keep them informed, I think the transparency and the input is going to be invaluable. And we need to consider new voices as new data comes in so that people can make good decisions with what is appropriate and what might not be appropriate.
Yeah, I'm just, nodding there, Craig, because I think that's exactly it. And that's exactly the sort of the idea behind the considerations around privacy and security for health data utilities. Because again, when we talk about HDUs, we talk about use cases and we talk about governance appropriate for those use cases. And so if you're talking about a data set that affects a particular group of people, then you've got to have them be part of that governance model, specifically and directly. And so with that, the preferences of the people who the data is about, who the data affects, that's critically important in figuring out what are the appropriate and necessary privacy and security policies. I also will turn around a little bit and say, there is a big issue at the national level right now in response to the federal legislation and regulation around patients accessing data through electronic means using any sort of app of their choice, because the federal government declined to put any requirements around registration or specific practices that those third-party apps bring to the table. And so it is now a private sector effort through organizations like the Karen Alliance, trying to sort of create voluntary models for safety and security of third-party apps that patients can use to access their electronic health data. And so every state, every jurisdiction, every health system, even every provider needs to think about the fact that patients, in many cases, will be able to use any type of third-party application to access their data. And then you move into a space where it's like, well, yes, technically the patient was the one who took the risk, but also all of us are responsible for keeping health data safe and having appropriate privacy and security practices. So there's a real tension that's going to affect everybody, including the emerging health data utilities. So I think there's just some issues that they're not even directly about HDU, but they are totally affect the way HDUs will develop and think about privacy and security practices. And then finally, I would just say, hey, we just simply don't have enough exchange of health data for things that people want to exchange it for. Fundamentally, we are still in a world where it is hard for patients and even for providers to get appropriate access to comprehensive health records. And it's hard for public health, and it's hard for community health. It's hard for everybody still. And so I also just think we have to remember that that's an issue that is equally important as protecting data, is making sure that it actually gets used for the right purposes.
And Lisa's national perspective is really valuable to states, and it's certainly valuable to the discussion in this presentation, because I think she articulates a couple of areas that are just critically what I would call challenges and areas of concern. When you think of consumers having access to their data and it comes through an app from an HDU or an HIE, if there's a risk, or if indeed a breach occurs, consumers are going to pull in time and time again the source of where that information came from. And the source was delivered through an HIE or an HDU. And really being able to address that, I mean, it's a challenge because it puts these organizations under the spotlight of being somewhat in a defensive position more often than not. At the same time, what I would say is it's an exponential win with every connection an HDU or HIE makes, because it's not one brings one. If you have a successful connection to public health and the providers see the benefit of it, now you get many more providers coming to the HIE. And so it really creates sort of a catapulting reaction when in our case, the HDU being CRISP, is able to make these connections. It drives people to it, as opposed to what we had many years ago, where when you see one provider, and CRISP was always struggling to pull in one at a time. one at a time, and like most HIEs did then. But it's been really helpful to have this kind of approach because it's moved things along quite quickly.
Great, thanks. We do have one question from our audience. I do want to get to those questions before we wrap up in the next 8 minutes or so. It's from Elizabeth Davidson. Large provider networks and national insurers see proprietary business value in holding their own data beyond sharing for patient care specifically. How can the HDU address this tension? Is winning over stakeholders enough, or is regulation also necessary?
Yeah, this is the question, right? Technical interoperability and exchange issues are certainly still there. I don't want to claim that it's like super easy and everything is perfect. It's not perfect, of course, but the major technical challenges are known, can be overcome. They are accessible. The challenges to interoperability and exchange and appropriate use of health data in our healthcare system is competitive, anti-competitive behavior between healthcare entities. 100 million%. That's where we are today. People using HIPAA and other things as a cudgel to block the sharing of health information. And of course, there are attempts at the federal level to address this. But I think truly for health data utilities to push back against this is really to get the stakeholders at the table, to be driven by and supported by real policy levers at the state or jurisdictional level. And those levers can say, hey, we're Medicaid, and I'm not talking about Maryland specifically, we're Medicaid, and you have a Medicaid managed care organization, and in order to have that license from us, essentially, shorthand there, you got to share information in this way. Or, we're public health, and we're asking you to do this. This is our authority. Plus, the voluntary, we see value in it, engagement from those stakeholders. And that takes coordination. That's governance. That's multi-stakeholder governance. Is bringing everyone to the table, getting them to agree to something, and working through it and refreshing it all the time. It is not easy. It is not fast. It is not perfect. It's a messy human relationship activity that takes a long time and a lot of great leaders at the state level and at the community level to make it work. But that's exactly it, Elizabeth. That's where those things can happen. That's my take. I'm interested in my colleagues' perspective as well.
So I would invite Kenneth to talk in just a second, but I'll sort of tee him up a bit in that I believe there are 18 states, and I may have this number wrong. I'm sure he has it off the top of his head, that are considered to be APCD states. And what happens is more of these states begin integrating the APCD data, making it available to an HDU or an HIE. It somewhat begins to nip away at the challenges of the concern that Elizabeth raised in her question. Also in Maryland, through the wisdom of the Maryland General Assembly, legislation was passed that requires, as we heard Kenneth talk about, claims clearinghouses to make these electronic health transactions be available to the HIE. So there's to Lisa's point, I think she summed it up very well. There's not a single pathway to resolving these challenges. It's chipping away using multiple approaches. And Kenneth, can you say anything about this process?
So I think with standardization, a common data layout in order for states to communicate, even APCD data, to HDUs, because the thing is that one thing these carriers or payers really push back is that each state have its own data format, and that is enormous burden. To really have 18 to 19 states, and between that you have like 4 different files, right? So that becomes enormously burdensome. So if you could have a standard format, the common data layout that states have worked on when the ERISA took away that information. The states have actually come together to decide on a common data layout, which some states are slowly adopting. But I think that is the key: standardization for everything, to really lessen the burden, of reporting, and then people would be more incentivized to share information, across states, even with health data utilities as well.
Thanks. No more questions for the audience. So I'm going to punt up a really quick question for Ken again to expand upon what he was talking about with the APCDs, and how can the APCD, with these the recent issue with the ERISA and having all that data no longer part of the APCD, can you discuss how APCD states can be able to support healthcare reform, and what other opportunities to leverage the APCD for new care delivery models, particularly considering what just recently happened with the ERISA?
Well, one of the things, it depends on what your population is, right? Now, if you are, for instance, if you are doing analysis that only includes like the full insured population, then there is a data really doesn't matter, right? Because that is self-insured, and things like we have in our state like mandate studies, which only affect the full insured, but the other thing with the loss of the self-insured data is like practices, when you attribution of patients to practices. Now, if you have, before the ERISA happened, if you have a practice that is on the fringe, kind of small, very, when that ERISA data was lost, or even the federal employees, that small practice, that data becomes really not credible at all, because attribution becomes a really problem there, So also some of the things I talk about with like the clearinghouses, that is one area that we can look at. But what we're doing here in Maryland, we look at data using the MEPS-IC. If we want to calculate information just based on, not at the patient level, but at the aggregate level, like for per capita cost calculations, what staff did here in Maryland was to develop a regression model to use the fully insured large group, to estimate what that ERISA claims are going to be going forward, and also use the MEPS-IC for the enrollment in order to really calculate those per capita costs. We do this calculation for HRCSC for them to report to the federal government as well.
All right, thank you. I believe we are at time. I appreciate all of your comments and your discussions on this topic. And then I will kick it